Thank you for the introduction, Professor Misch. I indeed I'm going to tell about the management of metabolic disorders during regional citrate anticoagulation. So in regard to this presentation, I have no conflict of interest. Criteria for the start of renal replacement therapy in ICU patients with acute kidney injury were already mentioned by Professor Sarbok, but once again, the indications according to the guidelines are life-threatening fluid overload with no response to diuretics, and refractory potential life-threatening hyperkalemia, severe metabolic acidosis refractory to conservative treatment, and uremic complications. And when there is a need to start renal replacement therapy or continuous renal replacement therapy in an ICU patient, there's also a need to start anticoagulation for the circuit, because otherwise the filter survival time will be very low. And when you then compare the filter survival time between circuits anticoagulated with citrate versus circuits anticoagulated with heparin, there is an increased CRT circuit survival time with regional citrate anticoagulation compared to heparin. So the guidelines advise to use citrate anticoagulation as first-line anticoagulation strategy, except in case of liver failure. So prior to the start of CRT treatment, there are often metabolic derangements, but also during CRT treatment, as a side effect of citrate anticoagulation, metabolic derangements might occur. So metabolic acidosis might persist or may become progressively worse. Also metabolic alkalosis might develop, and hypo and hypercalcemia might arise. So it's important to do close monitoring of laboratory parameters during CRT treatment with regional citrate anticoagulation to avoid or otherwise timely diagnose metabolic complications. So before discussing the actual citrate effects, I will first show you two schematic CRT circuits. So first of all, a continuous veno-venous hemofiltration circuit on which only a convective flow is applied. And then now a continuous veno-venous hemodiafiltration circuit with an additional diffusive clearance via an extra dialysate flow of the circuit. And then about citrate. Well, citrates prolongs the circuit survival time by binding to free ionized calcium. And free ionized calcium is an important factor for the activation of coagulation. When citrate anticoagulation is applied in a CRT circuit, it's done via a pre-filter substitution flow which already contains citrate. So this citrate then subsequently enters the circuit and will bind to free ionized calcium, and part of this calcium citrate complexes will be returned to the patient, and in the patient this citrate will be metabolized or converted to bicarbonate in such a way that one molecule of citrate will result in the formation of 3 molecules of bicarbonate. This process is mainly done in the liver, and for a small part also in skeletal muscles. So when there is a severe disease of the skeletal muscles, such as severe myositis, this conversion might be impaired, but more often impairment of liver function is a reason for a diminished conversion of citrate to bicarbonate. Actually, most of the calcium citrate complexes do not reach the patient, but are actually lost in the effluent. So therefore, the amount of citrate reaching the patient is not enough to regain a normal acid-base balance in the patient. So therefore, the post-filter substitution flow fluid also contains bicarbonate. And when you use CVHDF and you have this dialysate flow, it's important that this dialysate fluid does not contain calcium, because otherwise you would undo, at least in part, the citrate effects in the filter. Well, and because besides loss of citrate, there's also a lot of calcium lost in the effluent. So before the blood is returned to the patient, the calcium needs to be supplemented. And since citrate does not selectively bind only to calcium, but also to magnesium, also a lot of magnesium is lost in the effluent. So also magnesium needs to be supplemented. Well, then about the metabolic disorders, we're going to discuss about metabolic acidosis, metabolic alkalosis, and hypo and hypercalcemia. So first of all, metabolic acidosis. Well, when metabolic acidosis occurs during regional citrate anticoagulation and is thought to be due to regional citrate anticoagulation, there are two possible causes for this. First of all, the citrate infusion rate might be too low for adequate formation of bicarbonate from citrate. And secondly, there might be citrate accumulation, in which there is a diminished conversion of citrate to bicarbonate. And how can you now differentiate these two conditions from each other? Well, that can be done by using the anion gap and the calcium ratio. So first of all, the anion gap. What is actually the anion gap? Well, the anion gap is the gap between the most abundant cation in the blood, which is sodium, and the most abundant anions in the blood, which are chloride and bicarbonate. And the gap between these two, the cations and the sodium and both combined bicarbonate and chloride will form the anion gap. And then this anion gap represents the unmeasured anions, which are all anions except for bicarbonate and chloride, such as phosphate, lactate, proteins, and then mainly albumin, and also citrate. So when there is citrate accumulation, there will be an increase in the anion gap. So how can you calculate the anion gap? Well, that can be done by using the formula on the slide, and you see then that the anion gap needs to be corrected for the albumin level, and that's because proteins are part of the anion gap. So when there is a change in the protein level, it will have an effect on the anion gap. And also, when looking at an anion gap, it's also important because to look at the lactate levels, because ICU patients frequently have an increased lactate level, and lactate is also part of this anion gap. So when a patient has an increased anion gap, but also an increased lactate level, you first need to know what is the lactate part in the anion gap before you can say the anion gap has another cause, such as citrate accumulation. So when you so sometimes you need to subtract the lactate level from the anion gap, and when you then still have a high anion gap, metabolic acidosis, in this condition, it's very likely that there is citrate accumulation. Well, we come back to the anion gap during the case discussion. So when it's not entirely clear right now, I hope it will be after discussing the cases later on. And then about the calcium ratio, which is actually the ratio between the total calcium and the ionized calcium. And the total calcium is built up from three components. First of all, in red, the ionized calcium part, and then in green, the protein-bound calcium part, which is mainly calcium bound to albumin, and then in blue, the complexed calcium part. And in case of calcium citrate accumulation, the calcium complex part will increase largely due to the calcium citrate complexes, which results almost always in an increased total calcium. And because the ionized calcium in part more complex to citrate, the ionized calcium level decreases. And by using the calcium ratio, you get insight in this effect. And when you use this calcium ratio, it's important that you use a recent total calcium. The importance of that will also become clear when discussing the cases later on. So, and when the calcium ratio is above 2.5, calcium citrate complex accumulation is actually present. So then you have to take measures for that. And in many hospitals, citrate accumulation is already suspected when the calcium ratio is above 2.5. So back to the metabolic acidosis and the two options. Well, in case of a too low citrate infusion rate, the anion gap will be normal and the calcium ratio will also be normal. But in case of citrate accumulation, you will have an increased anion gap and or an increased calcium ratio. So when the citrate infusion rate is too low, possible solutions are to increase the citrate dose to have more substrate for bicarbonate formation, or to increase the blood flow, which means per unit of time more citrate is added to the circuit and subsequently also to the patient. And in case of citrate accumulation, you actually need to do the opposite. So you need to decrease the citrate dose and or decrease the blood flow. And when the acidosis then persists afterwards, or the calcium ratio stays high, you need to stop citrate treatment. Well, then about metabolic alkalosis. Metabolic alkalosis is actually caused by a too high net bicarbonate infusion. So too much citrate is converted to bicarbonate. Possible solutions are the use of a post-filter substitution fluid with a lower bicarbonate content. In our hospital, we recently changed our CRT protocol to a protocol with a higher citrate dose, but also simultaneously lowered the bicarbonate content in the post-filter substitution fluid and in the DDSAT fluid. And despite using a higher citrate dose in the new protocol, we did not find more metabolic alkalosis. And that's because we used this lower bicarbonate content fluids. Other options are increase of the post-filter substitution flow, because when you do so, the machine will also increase the effluent flow, and by that means more calcium citrate complexes will be eliminated from the circuit. And you can also lower the citrate dose, but you should not lower it below 2 millimoles per liter, because otherwise the anticoagulant effect of citrate will diminish a lot. And it's also good to keep in mind that the effect of an adjustment can usually only be seen after more than 12 hours. So you need to be patient before you take an additional measure. And then about hypo and hypocalcemia. When you've got a low ionized calcium, you need to calculate the calcium ratio. And when this ratio is then increased, well, it means that you have citrate accumulation. This means that you actually need to lower the citrate anticoagulation dose, or even need to stop citrate anticoagulation. And in case the ratio is normal, it means that you supplement calcium just not enough, so you need to increase the suppletion. And then when you've got a high ionized calcium, well, you can lower the calcium magnesium suppletion. And you can also increase, once again, the post-filter substitution fluid, because then the effluent flow will be increased and you will also lose more calcium in the effluent. But by that means, you might also lose more, of course, more citrate and have less substrate for bicarbonate formation. So it can also have an effect on the acid-base balance. Then about the prevention and detection of metabolic complications, frequent monitoring and interpretation of laboratory parameters is necessary. So within 2 hours after CRT start, you need to measure the ionized calcium level, as well as the sodium chloride, bicarbonate, and lactate level, and repeat that 3 to 4 times a day. And you should also daily measure total calcium level, magnesium levels, and albumin levels. And in case of metabolic acidosis, you need to calculate the anion gap once a day. And in case of progressive metabolic acidosis, you need to do so every 6 hours. And in case of a low ionized calcium level, you need to calculate the calcium ratio. So in summary, during treatment with regional citrate anticoagulation, metabolic acidosis might occur, which can be caused by citrate accumulation due to incomplete conversion of citrate to bicarbonate, and can also be due to insufficient citrate infusion, by which means there is insufficient citrate as substrate for bicarbonate formation. You can distinguish these two from each other by using the anion gap and the calcium ratio. Also, metabolic alkalosis might develop due to a too high net bicarbonate infusion rate. And to see these metabolic the development of these metabolic derangements early on, it's necessary that laboratory parameters are frequently assessed.